Welcome to Healing Horizons. I'm Chris Daniels, and today we're asking a hard question. In the era of fentanyl, why are many traveling to Mexico for Ibogaine therapy? This episode offers context, cautious optimism, and realism. Quick disclaimer: educational content, not medical advice. Ibogaine is powerful and risky. Decisions belong with licensed clinicians who know your history. Our aim is to illuminate responsible pathways to recovery and harm reduction, not to promote unsupervised use. Let's start with the crisis. Fentanyl saturates the illicit supply in heroin, pressed pills, and stimulants, driving record overdoses. Potency varies batch to batch, and analog contamination complicates response. People cycle between withdrawal and fear of poisoned product, while waitlists, cost, and stigma limit care. Medications for opioid use disorder save lives, yet many still relapse or carry untreated trauma and despair. That context fuels interest in Ibogaine. Ibogaine is an alkaloid from the iboga shrub, revered within Bwiti traditions in Central Africa. In modern settings, it's used under medical supervision to interrupt dependence. Unlike conventional detox with tapering and symptomatic meds, Ibogaine induces a long, introspective state while often reducing acute opioid withdrawal. People describe revisiting memories, sensing patterns, and emerging with a pause in cravings. It is not a psychedelic party. It's intensive, taxing, and medical. How might it work? Ibogaine and its metabolite noribogaine act across receptor systems, NMDA, kappa opioid, sigma, and inhibit serotonin transporters, potentially easing withdrawal and lifting mood. Noribogaine's longer half-life may provide a temporary antidepressant-like cushion. Early data suggest neurotrophic effects and disruption of conditioned cues, offering a window to reset habits. These are models, not guarantees. The experience can open a door, but walking through requires preparation and aftercare. What does the evidence say? Open-label studies and observational cohorts suggest Ibogaine-assisted detox can reduce acute opioid withdrawal and cravings, aiding transitions into recovery. Some follow-ups show months of reduced use or abstinence, especially with aftercare. Yet samples are small, methods vary, and no large randomized trial exists for opioid use disorder. Adverse events, including cardiac complications and rare fatalities, demand rigorous screening and standards. Promising, incomplete, and safety-dependent, that's the evidence picture today. Why is Mexico a hub? Ibogaine isn't scheduled federally there, allowing licensed physicians and experienced teams to operate clinically. Over years, practitioners have developed protocols, and costs can be lower than private care elsewhere. Travel access from the US and Canada is straightforward. Quality, however, varies. There's no single national standard, so due diligence is vital. The best centers pair medical oversight with ethics, clear communication, and aftercare planning. Not miracle promises or luxury gloss. Safety comes first. Responsible programs complete thorough screening. History, medication review, physical exam, EKG for QT interval, and labs for liver, kidney, and electrolytes. During treatment, continuous or frequent cardiac monitoring, pulse oximetry, and trained staff are standard. Facilities need emergency equipment, protocols, and rapid transfer plans. Risks include arrhythmias, liver strain, ataxia, and psychiatric destabilization. Those risks become manageable only with preparation, selection, and oversight, never in informal or non-medical settings. Contraindications matter. Many medications and conditions increase danger with Ibogaine. Examples include QT-prolonging drugs, certain antidepressants, antipsychotics, stimulants, and methadone. MAOIs are unsafe. Significant cardiac disease, uncontrolled hypertension, seizure disorders, active liver disease, pregnancy, and untreated psychosis or bipolar mania are red flags. Buprenorphine requires careful planning under medical supervision if transitioning. Never alter prescriptions without your prescriber. Competent clinics coordinate with providers, adjust timelines, and When risk is high, recommend alternatives rather than proceed. Fentanyl adds complexity. Its potency and tissue persistence can prolong withdrawal and complicate timing. Many teams recommend longer stabilization and washout than with short-acting opioids, guided by clinical assessment and objective measures, not guesswork. Medically supervised transitions can reduce risk, but shortcuts backfire. After Ibogaine, tolerance drops dramatically. Returning to prior amounts can be deadly. Plans must include overdose prevention, support during vulnerable weeks, and clear contingencies, not the assumption that cravings will stay quiet. A responsible protocol begins with comprehensive intake, records review, and medical clearance. Stabilization addresses sleep, hydration, nutrition, and mental readiness. Physicians individualize dosing based on weight, labs, medications, and cardiac findings with continuous monitoring and a conservative posture. Staff support mobility, hydration, and bathroom safety. The day after, reassessment guides next steps. No high-pressure timelines, no one-size-fits-all doses, no shortcuts. Protocols extend beyond the clinic with planned aftercare and communication. Set and setting shape outcomes. Preparation includes clarifying intentions, identifying triggers, and arranging supports at home. During the experience, a calm, medically equipped environment matters, trusted staff, and minimal interruptions. Post-session, integration translates insights into behavior, journaling, therapy, and small, repeatable commitments like sleep hygiene and movement. Expect emotional waves and fatigue. Plan for gentleness, routine, and connection. Integration is the daily practice of aligning choices with what you learned. The first 90 days are pivotal. Build a scaffold before you travel. Weekly therapy, peer support meetings, recovery coaching, and primary care follow-up. Arrange safe housing, a structured schedule, and contingencies for cravings or sleep disruption. Consider evidence-based medications, buprenorphine or naltrexone, when appropriate and coordinated by your clinician. Nutrition, exercise, and circadian regularity stabilize mood. Reduce exposure to high-risk environments, enlist accountability partners, and define specific daily routines that make the next right choice easier. Whatever your path, harm reduction saves lives. Carry naloxone and teach friends and family to use it. Where legal, use fentanyl test strips. Never use alone. If you must, connect with a virtual spotting line. If you're not ready for cessation, consider buprenorphine or methadone, which substantially reduce overdose risk. Access sterile supplies, wound care, and hepatitis and HIV screening. Reducing harm today keeps the door open for recovery tomorrow. How do you vet a clinic in Mexico? Start with medical leadership. Licensed physicians experienced with cardiac risk present on site. Ask about EKG and labs before acceptance, continuous monitoring, and 24/7 staffing. Confirm ACLS training, defibrillator, emergency meds, and hospital proximity with a transfer plan. Review written protocols, informed consent, and how they handle contraindications. Request aggregated outcomes and adverse event reporting. Look for integration partnerships, transparent costs, and ethical marketing. Guaranteed cures? Walk away. Ibogaine's story begins long before clinics. Rooted in Bwiti's spiritual practice, it deserves respect. Ethical participation means avoiding extractive attitudes, supporting conservation of Tabernanthe iboga, and crediting indigenous knowledge. In Mexico, some programs blend medical care with respectful ceremony or mindfulness without appropriation. Ask how a clinic sources medicine, compensates workers, and gives back. Healing is relational. Acting with integrity protects people and plants and deepens the meaning of the work. 3 brief perspectives. First, a patient in her 30s using pressed pills found relief from relentless withdrawal, then built stability through therapy, buprenorphine afterward, and community. She calls Ibogaine a reset that made change feel possible. Second, a clinician notes their best outcomes when patients arrive medically stable, with clear aftercare and family involvement. Third, a researcher sees promise and gaps. Signal in observational data, plausible mechanisms, but a mandate for trials, registries, and standardized safety reporting. Legal and logistics. In Mexico, Ibogaine is unscheduled, but regulation is heterogeneous. Plan travel with rest buffers. Don't schedule return flights immediately after treatment. Bring medical records and a prescription list. Consider traveling with a trusted support person to help with meals, errands, and grounding after discharge. Choose recovery-friendly lodging for several quiet days. Hydrate. Eat simply. Avoid major decisions. Jet lag and overexertion can sabotage integration. Give your nervous system time to settle. Let's set expectations. Ibogaine is a catalyst, not a cure. It may reduce withdrawal, interrupt patterns, and spark insight, but it doesn't install new habits or heal relationships overnight. Informed consent means understanding benefits, risks, alternatives like buprenorphine or methadone, and the possibility of no benefit. It also means clarity on costs, refund policies, and support if complications arise. Courage is preparing wisely and accepting help. Recovery is built collaboratively, step by step. That's our time today. We covered a lot. The realities of a volatile fentanyl era. What Ibogaine is and how it differs from conventional detox. Plausible mechanisms that may reduce withdrawal and cravings. The current evidence, encouraging but incomplete, and why Mexico has become a hub. We talked about safety fundamentals, medical screening, continuous monitoring, and emergency readiness, contraindications and medication interactions. Fentanyl-specific concerns like tissue persistence and overdose risk after tolerance resets, and what responsible protocols actually prioritize. We explored setting, and integration, practical aftercare for the first 90 days, and universal harm reduction, naloxone, test strips, never using alone, and evidence-based medications like buprenorphine or methadone. We discussed how to vet a clinic, cultural respect for Iboga's roots, brief real-world perspectives, and the travel logistics that make recovery more sustainable. Here's the takeaway. Ibogaine can be a powerful catalyst, but outcomes hinge on preparation, safety, and sustained support. If this episode resonated, speak with a qualified medical professional who understands addiction medicine and can help you weigh options. As always, this podcast is for education only. I'm Chris Daniels, and this is Healing Horizons. Thanks for listening, and may your next step be steady, supported, and aligned with your deepest values. Stay safe,